Hi, John. Good morning. How are you?
Very happy that we have a certain personality with us today who we've been having a good laugh with. Great for the listeners.
Yes, this is true. So in our recording studio, we have Professor Markus Peck from Austria. So very privileged. Thank you for being with John and myself on Med Insights Unleashed. Professor Peck, can I ask you to briefly introduce yourself?
Yes, of course, Sarah. It's a privilege for me to be with you and have this interview. I'm Markus Peck, living in Klagenfurt at the moment. Most of the time I spent in Vienna at the medical university. I'm a gastroenterologist and hepatologist who has been working in several fields, but lately mostly in the field of HCC.
You are how many kilometers from Vienna? And it's a lake town, correct?
It's halfway between Vienna and Venice. So it's 330 kilometers to Vienna and about the same distance to Venice on a straight line. So it's in southern Austria, very close to the Italian border, about 20 minutes to Italy, about the same amount of time to Slovenia. And it's on a lake called Wörthersee, which is a very scenic lake and a holiday vacation spot.
Wow, sounds
Where you
wonderful.
go, and you go windsurfing there a lot. We know that because that's part of your hobby.
Well, I would love to, but there's not a lot of wind, which makes it a great lake for swimming, for water skiing and all these kinds of sports, and maybe even sailing. But I go stand-up paddling, actually. That you can do almost every day.
Oh,
Yeah.
nice. Yeah, nice.
Great. Well, thank you. It's always good to have a good balance of life and work. Professor Peck, the topic that we're discussing today, I think, is something very important and very relevant. And it's around the risk that patients are almost taking sometimes when they start having that conversation with you, the clinician, around more aggressive treatments. So you being in Austria, being a hepatologist and a gastroenterologist, can you further elaborate, walk us through some of the conversations that you have with patients around that?
Well, I think it is quite important because when you, as a physician, I think most physicians do that. When you think about a procedure or a treatment, usually you think about the risks or the benefits of this treatment. And not always you make yourself aware of the fact that it's not the treatment that has the risk, but it's the patient who has the risk. And I think as a physician, you are always more inclined to look at the benefits of the treatment. And that's what you kind of convey to the patient. However, when you're on the other side, when you're a patient, for example, just undergo a non-dangerous procedure, minor surgery, you become acutely aware of the other side, where you just think about minimal mortality risk is still a mortality risk, right? And you are concerned. And then if you think about a major surgery and you have a 3% mortality risk, which you would have in a major liver surgery, for example, for liver cancer, that becomes a major concern for you as a patient, but not so much for you as a physician. So it's these different points of views that make a big difference. Now, this is surgery, and medical treatments or interventional treatments carry a lower risk of immediate death, but they do have a certain risk that the treatment will actually make you worse and not make you better. And I think,
Right.
I became aware of this fact in the early 2000s when we started to work more intently on PACE for HCC, which at that time was, for many patients, was the only treatment we could offer. No drug treatment was available. Surgery was for many patients not an option because their liver disease was too much advanced, so you could just not risk it. And then you would do a taste on your patient. And then, some patients were doing well, but many patients were not doing well, and you were kind of accepting that risk. But for the patient, it might have been very different if you would showed him that more clearly, and we were not able to do that because it was only the start of the work on risk scores, how to look at predictors, which patients would be doing well, which patients would not be doing well. That's when a lot of this research started off. But it made me aware of the fact that we're not looking at this sufficiently oftentimes.
You're a hepatologist and a gastroenterologist, so you're looking after this patient with the early stage disease, and you have a long time with these patients. Are there patients that are more at risk?
If we talk about liver cancer, oftentimes these patients have two serious diseases. One is the tumor, and the other one is the underlying liver disease, which they have. And even though in NAFLD or MAFLD, however you want to call it, you do have a significant number of patients that don't have cirrhosis. With many other disease etiologies, the patients will be cirrhotic patients. So their liver function will be impaired to a variable degree, and that has a large impact on the outcome of treatment.
How do you then have, given the risk, as you just mentioned, that the patient is exposed to, how do you as a clinician have that conversation? Do you have that conversation with that patient?
We certainly have the conversation with the patient because when it's not totally clear cut what you want to do with a certain patient, then you have to assess the patient's views and values, whether he would want to take more risk in order to get a maybe more effective treatment, or whether the patient says he wants to have less risk and accepts that his disease will progress maybe more rapidly than otherwise, but he will have time that he can more time that he can spend at home without being at risk. Because you can, I don't know, for example, if you perform TACE, your median survival might be 2 years if everything goes correctly. If you have very good liver function, your survival might be 45 months, almost 4 years, right? But if you're a poor risk candidate with poor liver function and a larger tumor, you might be dead in 3 months. So, because you cut arterial blood supply, and that might drive you into liver failure, and we've seen that. This is what you have to discuss with the patient, depending on his very specific disease stage, both with regards to the liver function, but also with regards to his tumor size and how you could treat it. To some extent, it is also true for drug treatment, right? Not only for interventions, because your drug treatment will have certain side effects, a certain degree of efficacy. And so you have to balance this.
I was just wondering, that offers a great conundrum to you, the doctor, when a patient that may have a poor prognosis and has significant underlying morbidity asks for a aggressive therapy. So how does that conversation go? Because you need to take that patient's total well-being into consideration. It must be difficult for you and the patient to have that conversation.
It's Well, difficult, it's the situation might be difficult. Sometimes the situation is very clear, which means the patient is not able to tolerate any of the treatments that he might want to desire. And then you tell him very clearly that this is not something that can be done or should be done. And that may be disappointing for the patient, but the conversation is not so difficult because you can give him good reasons and you can tell him with all your experience that you've seen it, you have done it, and it's not a good idea to do that. And you as a physician will just not do that. And then most patients will accept your opinion. It's more difficult in the situations where there is a slight chance, because then you cannot give the patient such a clear-cut recommendation. You can still give him a recommendation. But let's say you have a patient who should undergo drug treatment with a drug that is known, that's an anti-angiogenic. It's known to be able to cause problems in his arterial system. He's already got arterial vascular disease. He might have had a stroke some time ago. The drug increases the blood pressure and stuff like that. And then he might have, because he's diabetic, he might have a poor kidney function already, losing proteins through his kidney. There are some contraindications. Many of them are relative, not absolute, especially if the comorbidities are dating some time back. So there's no acute situation. And then you have to counsel him.
So the question that I have is just to go a few steps back. When we're talking about the risk that patients are willing to take, they want more aggressive treatments. There's maybe, like you said, lack of back in the 2000s, like of appropriate risk scoring. Where does trial selection come into this? Do you think that is part of the problem? Is that clinical trials are they have strict criteria. And so as such, that patient that's sitting in front of you is not your typical patient that would have been part of that clinical trial.
If the patient has significant comorbidities, he most certainly would not have been part of a clinical trial, and this type of patient would have not been part of any clinical trial. And that is important because the clinical trial has to reduce the variables that you have, right? Because you want to test a certain treatment. You don't want to test the effect of the comorbidities. But I think for me, at least for me, this is not the biggest problem, because I believe that a certain drug, for example, works in a patient that has no comorbidities as well as in a patient who has comorbidities.
Okay.
But it might cause more toxicity, or the toxicity might be more visible, I should say. It might cause the same type of toxicity, but you see it more and it might matter more for the patient. You're taking this into account. You can not really quantify this type of risk. You cannot tell the patient, your risk of getting a stroke is 50%. You will never be able to tell that to a given patient. You can just tell him it's increased.
Just elaborate on what you just said then. In your hospital or in your practice, what mechanisms have you included that really support the patient, especially that high-risk patient, where you know that this patient's going to get more side effects? Do you manage that patient differently to other patients?
I think it's just really important to make the patient aware of the risks and try to understand what he wants in life or with his remaining life. What are his priorities? And how does he feel, for example, about not getting treatment? Because this is also very stressful for a patient. And he might, just for the sake of his mental health, want to to try some treatment, because he just can't stand knowing that he has a malignant disease that's progressing, but he's not getting any kind of treatment. It's very hard on most patients. And this is what you evaluate together with the patient and try to understand. So support, what we offer is, of course, an open door to our patients. If they have a toxicity, they can come more or less anytime to be helped. And of course, we tell them what to expect and what's more likely to happen, what's less likely, which side effects we think are of minor importance and don't need immediate action, and which side effects are important and they should come and see us more or less immediately.
The question I had was around, patients perhaps requesting or wanting more aggressive treatments or therapies, evaluating the risk. But then when you offered them, when you kind of had that conversation with the patients, and let's just say they don't align or don't agree, within your institution or even within Austria, how do second opinions come in? Like, hey, doc, I'm actually going to go and get another opinion from another clinician. And John and I were having a conversation earlier around second opinions. And so how does that play in, or does it?
I mean, any patient is free to get a second or a third opinion in Austria. I mean, he has to organize it himself, which means he has to make an appointment. We don't make an appointment with a different doctor in a different hospital. He has to make it himself. But
Right.
there is no major barriers to that. And
Okay.
I think it's fine. Usually the opinion they get, there's not divergent opinions when it
Thank
comes to standard treatment. Now, when we get into third line, fourth line treatments, there might be different opinions. That I can understand very easily, because when there's no rules, there's different things that people take into account. Nobody, at least not in our country, has enough experience with hundreds of patients on fourth line treatment. It really comes down to looking at individual factors, looking at study results, remembering subgroup analysis, maybe, with all the weaknesses they have. And again, looking at risks and potential benefits and trying to balance.
Can I just
And
ask
then,
you to
yeah.
explain to the listeners about subgroup analyses, what that means?
So when you do a study, you define your study population, and you usually define it fairly narrowly, but still they're not all the same. Usually you will have, for example, male and female patients, so each of them is a different subgroup, and they might respond differently to a certain type of treatment. Also, you might have or usually have geographic variation. You have Caucasians, you have Asians, you might have, I don't know, African Americans whatsoever. And these patients might respond differently to treatments. Or in the case of liver cancer, as I said, you usually have two diseases. You have the cancer, but also an underlying liver disease. And this liver disease might be caused by a virus, might be caused by alcohol, might have a metabolic cause, or some of the more rare diseases. So, and each of these groups might respond differently to the treatment or not. So these are the factors that you will look at when you have to make a decision where you don't have a very clear-cut recommendation for everyone.
Thank you.
The more lines that you're using, usually quality of life becomes more and more important. When you're dealing with a patient and you go to the first few lines of treatments, they already suffer some toxicity. Initially, when they start with the first line of treatment, many patients are extremely motivated and are kind of wanting to put up a fight against this tumor. But then as time progresses and they suffer some toxicity, and at the same time, maybe no efficacy, they start to become more conscious about the toxicity of drug treatment and say, okay, I know the next line, there's a possibility that it's effective only for 3 months, or there's a possibility that it's even not effective at all. And how much quality of life am I willing to sacrifice for a treatment where I already have 3 treatments that were not terribly effective?
I wanted to go back to this because the whole trial selection criteria is something that has always not perplexed me, but I've always had some questions around it with regards to the sometimes the stringent inclusion or exclusion criteria within clinical trials. So from your perspective and the conversations that you have with your patients, what are your thoughts around current selection criteria for trials? Do you think that sometimes they're too strict and again not really applicable to that patient that's sitting in front of you?
I personally don't think they're really too strict, because looking back in time, I still remember, because I'm old, the times when there was not such a stringent selection for trials, which led to a rather large number of trials not being able to show a benefit of the treatment due to the fact that there was too much variability in the natural course of the disease, simply because the entry criteria were too loose. And it was really only when people started to be rather strict with regards to the entry criteria that you were really able to look at the efficacy of a medication or a treatment, not only medication, treatment. And then, especially from the drug treatments, where we usually in phase 3 in HCC have a overall survival endpoint, but also have secondary endpoints like response criteria, right? Or progression-free survival. We know from these data that even if you're going into different groups of patients, usually the response is the same. For example, if you have patients with mild liver disease, which is usually the population that you would include into a phase 3 trials looking at overall survival, because you would have a minimal number of patients dying from liver disease, and everybody who's dying is actually dying or not dying from the cancer. And then you look into patients with more advanced liver disease, where a significant number of patients will also die from complications of liver disease. But the efficacy data with regards to response to a certain treatment are more or less the same. And so therefore I'm not worried. I am worried that regulators are using this to disallow in certain legislations the use of these medications that show anti-tumor efficacy in a population where the overall survival benefit has not been shown, or it's not possible to show it for the reasons that I just elaborated. That is, in my opinion, a bit unfair. In my opinion, also not the right approach. And that's why in clinical practice, we're not following this advice in all cases. So we are, by inference, using treatments also in clinical scenarios where that have not formally been tested in the phase 3 trial.
Does it make
Right.
it harder or easier for the patient to get access when you're doing that? Is that treatment being reimbursed?
So this really depends on your legislation, your country, and your reimbursement system. We can use treatments also outside the very strict limits of the trial inclusion criteria. And in other countries, it's completely impossible to do that unless the patient pays for the medication himself out of his pocket, then can do everything. But medical systems or insurance systems oftentimes restrict it to the situation where the clinical trial has been performed. In my opinion, it's not really justified.
It's not really justified because
the anti-tumor efficacy and therefore usually relief of symptoms is also there in patients that have more advanced liver disease, for example. And
right.
the toxicity is usually not higher. The overall survival is, of course, worse, but that usually does not justify not getting treatment, you know?
On a previous episode, we were actually discussing with Professor Vogel, who's a good colleague of yours, the disparity or the differences between the healthcare system in Germany and Canada. And regulators within Canada, and I'm Canadian, would not fund or reimburse a drug just based on phase 2 data. And this is specific around cholangiocarcinoma. You have consistent phase 2 data, it's a rare disease, but yet regulators don't fund it. Is this kind of what you're alluding to where you disagree? And similarly in Austria, would regulators require, the robust phase 3 data in order for reimbursement or access to that drug?
We were talking in this conversation about treatments where you had phase 3 data, but not for the type of patient that was sitting in front of you.
Right.
Yeah, with the more advanced disease characteristics or comorbidities. Now, with regards to the setting in more rare cancers, for example, cholangiocarcinoma, we surely can get treatment also based on phase 2 data in particular, and I know what Vogel was really alluding to, in patients with certain molecular subtypes of cholangiocarcinoma, where you have a strong biological rationality to treat the patient because he's got a certain mutation and the drug is targeting this mutation, and it's been shown that it's prolonging survival or at least prolonging disease-free survival. Yeah.
Mm.
And there you can make a very good and logic argument. Our reimbursement system in such cases would probably on a case-to-case basis give reimbursement. And also not only because of the greatness of their heart, but you could legally challenge it and you will probably win because there's no good reasons for denying a treatment that has a good biological rationality. So the question is always, will you outlive the legal decision? That, of course, might be an issue. But our authorities usually don't go into this type of legal battle, especially not for more rare cancers, where this situation often arises. Because if you have a common cancer, for example, lung cancer, one of the big indications, breast cancer, prostate cancer, you usually have phase 3 data because there's no reason for not having phase 3 data.
Right.
There's enough patients to run a good trial. So it's really more the rare cancers where it's difficult to find patients. You're already happy if you have a phase 2 with, say, 100 patients globally. You're already in very good shape if you have that. And it would be unacceptable not taking these results into account, even if it's only phase 2.
What's your medical center differentiating from other medical centers when it comes to treatment?
It's the third largest or fourth largest center in Austria. And Austria is a small country. It has 9 to 10 million inhabitants. And I think this is not only true for our center, but also for other centers in Austria, are really trying to provide the best state-of-art care to our patients based on scientific grounds. And we do have, I think, the capacity, the intellectual capacity, but also the willingness of our payers that they will allow us to treat patients, especially cancer patients, with anything that seems reasonable.
I like that intellectual capacity. I like that.
I like that a lot.
Sorry, I cut you off. Go ahead. I just wanted to say that. I think there are certain centers around the world where you're hoping that intellectual capacity comes in, but sadly it doesn't.
It's always I mean, if it's about human interaction, it's always about personality as well. And the approach is always dependent on your physician's personality as well as your patient's personality. And so probably, surely there are some matches that are good matches in a patient-physician relationship and other matches that are no matches without being anybody's fault. So I'm a good physician for certain types of patients, but not a good physician for other types of patients. And usually you realize that immediately in your first conversation because the
So
patient wants to hear different things from what you're telling him. Yeah.
exactly. They're
Is
not happy. They go to someone else.
is that part of the risk of treatment?
Well, it's part of the risk. Again, it's the patient risk. It's not really my risk, and so I try to be flexible in my approach because I know in the end that it's harm for the patient if he does not follow my hopefully well evaluated advice or well reasoned advice. Yeah. And of course I can adapt in certain ways, but I cannot adapt in other ways. So if you want maximum alternative treatment, don't come to me because I won't be able to help you here.
That's very important for patients to understand and have that conversation that you just pointed out with their doctor, right? So there's a equal footing between the patient and the doctor.
Yeah.
It's good advice.
Did you want to offer any additional advice or additional comments, closing comments?
I don't think there's really a lot of general advice, you know? I mean, one thing is it's good for a patient to be informed, you know,
Right.
but then when you're informed and you look for a physician who is an expert, accept that he might know better what to do because he might read the same articles or the same information that you have, but he's got a lot more experience. So, in his judgment, usually because of his experience, not because of what he's been reading, or not necessarily because of what he's been reading, he will probably, with all the uncertainties that are always around, will be able to give you a better advice. These days, oftentimes you find patients who try to convince their physician that their treatment decision is the better decision.
Do you think that that's brought on by education through advertising? Is it brought on by
Or is
the
it
internet?
Google?
Is it Google driven?
Well, I should say, of course, it's a lot easier to get a lot of information, and that's not bad in general. However, what is very difficult for a patient is to judge or gauge the information with regard to his personal situation because he might have the disease, but he's not really, mostly not aware what his disease stage is or what his very particular situation means for him with regards to a certain treatment. Because this is the granularity that you don't get from any online information, because
Yeah.
that you only get through months or years of discussions, tumor board discussions, where we not only discuss things, but also we learn from each other every week. So this is, a patient cannot have this. It's impossible. This is, I think, important because you see patients taking oftentimes strange decisions, or they go doctor shopping until they find a doctor who tells them what they think he should be telling them. It's fine with me, but oftentimes I don't see a good outcome of these practices.
I think you make a very good point because there is so much literature out there. And now with the emergence of AI, it gets even further complicated. And I think that would be a great other episode to explore with you. So please come back. But it further complicates the conversation with that patient, and also for that patient to be almost like you said, emotional or subjective. I think you made a really good point there.
So I can just tell what I do when I need a physician, because from time to time I need a physician myself. So I usually try to find a very good physician in the area that I'm looking for. And then, I investigate a little bit into who that might be. And of course, if you're a physician living in the community, that's of course easier than for a patient who does not come from this community. And then I go to the colleague, and I don't really read too much around. I listen to him, and if it makes sense, and I do it. I don't question everything, even though, I'm fairly educated medically. But if the person is trustworthy and I have a good feeling because of my pre-selection and then also my personal interaction, I will just follow.
Excellent summary.
You're a great physician. If I get liver cancer, hopefully I don't. I'm coming to you.
Don't try this at home.
Agree. This is not something that you want to sort of start yourself.
John, I think this has been a really good session with Professor Peck. Professor Peck, thank you again for your time. John, any parting words from you, my friend?
I have a lot to thank Professor Markus Peck for over the years. He hasn't committed, but what we're hearing is he may be coming back to MedInsights Unleashed to answer further questions on other topics.
It was another very interesting topic.
Well, thank you very, very much.
Yeah, it was a pleasure. Yeah. All right, good.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.